Hello, everyone. We're just going to give it a minute or so before we get started, but I want to say hello and welcome everybody to the webinar today. Hello, everyone. As you're joining, we're just waiting a little bit to let everyone connect, and then we'll get started in the next minute or so. All right, let's go ahead and get started. We have some introduction as everyone joins, but hello and welcome to the latest webinar in the Homelessness and Housing First series. Today's webinar is titled Housing First Promotes Health. I am Peggy Bailey. I use she, her pronouns, and I am the Vice President for Housing and Income Security at the Center on Budget and Policy Priorities. The Center on Budget, the National Alliance to End Homelessness, and the National Low Income Housing Coalition are excited to bring this powerhouse panel to you today. Among us, all of us here on the call today, the understanding that stable, affordable housing helps to improve people's physical and mental health is likely a no-brainer. But we can't take it for granted that this and the importance of this is widely understood. As we've grown our understanding of this connection, there is no doubt that the homeless community has made some mistakes that are important to name and that we're going to be resetting today. You know, in the past, we've used this narrative to center ending homelessness in a cost-effective narrative, which has turned out to be a little misleading. We can achieve cost savings for some people, especially those who have been extraordinarily expensive to the healthcare system, but not for most people. And we have also used this connection to decide who is prioritized for housing and services, which either intentionally or unintentionally leans harmfully into a narrative around who deserves care versus who gets left behind. So as I said, we hope that today's webinar is a chance to reset this conversation around housing and health improvements for people who are unhoused. This discussion will give you tools to explain the degree to which any intervention strategy that perpetuates barriers to housing ends up further harming people physically and mentally, which then makes it even harder for them to exit homelessness. Housing first, when done properly, which means centering the person who is unhoused and their ability to self-determine their own needs, is a first step towards improving people's health and stabilizing their lives. Today's panel will update us on the research and facts of the case, and then show us how to operationalize what we know works. With that, I'm going to pass it to our first speaker, who is Margot Kuchel, who is the Director of Benioff Homelessness and Housing Initiative at the University of California, San Francisco. Margot?
Thank you so much for having me, Margot Kuchel, she, her pronouns, and if we can get the slides up. Next slide. Thank you. And next slide. So housing, oops, sorry, go back a slide. Sorry. Thank you. Housing improves health conditions. When we think of housing, it provides protection from the elements, protections from many forms of violence, a place to rest, sleep, attend to hygiene, cook, store food and medicine, a stable address for receiving services and mail, a sense of belonging and stability. And in so doing, housing provides prevention not only against infectious disease, but the ability to engage in longitudinal healthcare, adhere to medication, and most importantly, prioritize one's health and physical and emotional well-being. Next slide. There is abundant evidence that housing promotes health. I'm just going to present some data from our recent longitudinal long-term study of older homeless adults, where we follow them for over a decade so far as they transition in and sometimes out of housing from a state of homelessness. We found, for example, that once people are housed, in the next, people who remain, if we compare them to the people who remained homeless, who are otherwise just like them, those who remained homeless compared to those who became housed had twice the odds of experiencing victimization in the next 6 months, 1.8 times the hazard of dying. They were more likely to die than people who looked just like them, who entered housing. And we have recently found that those who remained homeless had an elevated and ongoing risk of depression compared to people who looked just like them, who were housed. Next slide. Housing First, as we said, is the evidence-based approach to housing homeless individuals. A reminder that it is not a specific program, it is not housing only, but it's an evidence-based approach that prioritizes safe, permanent, affordable housing as the foundation. And I want to remind you that in Housing First, engagement in services or other prerequisites are not required. It leads to an individualized approach. And while it is not only for those with severe behavioral disabilities, there's a strong evidence base for those with those disabilities to thrive in permanent supportive housing offered on a Housing First basis. Next slide. When we think about Housing First, too often the narrative has shifted to blaming Housing First for many of the problems that are at the root, are problems of our severe and ongoing shortage of extremely low-income housing. I want to remind you that the right comparison for Housing First are the other alternatives, such as high demand housing, treatment first housing, or that individuals be housing ready prior to placement. These alternatives demand that people maintain sobriety, participate in treatment, or agree to intensive services as a condition of being housed. And in every study, these alternatives perform worse on every measure, not only of housing, but health and well-being than those who are housed through Housing First. Next slide. As I said, Housing First is a substantial evidence base, both from experimental evidence comparing Housing First strategies to alternatives and from real-world evidence from implementation of Housing First. And a reminder that all rigorous studies favor Housing First over the potential alternative strategies. Housing First, of course, does not in itself create housing, but nor does alternative strategies. Really, the appropriate comparison is with our existing housing, how does a Housing First approach compare to alternative possible strategies? Next slide. So what is the evidence for Housing First? Compared to those in treatment first housing, those offered Housing First stayed housed longer, had less shelter use, and were more likely to maintain their housing. What is the evidence for improved health? These studies have shown improved quality of life, decreased psychiatric symptoms, decreased substance use in some studies, and increased engagement in services, appropriate outpatient longitudinal services, while in most studies, a decrease in acute care services. Next slide. The alternatives to Housing First tend to struggle with engagement. Next slide. If you look at treatment first or sober living, there was just this making the news in the Bay Area where our BART, our transit agency, invested a good amount of money into a treatment first strategy. With $350,000 spent, they had treated only one person because they demanded that the person accept treatment on their grounds, as opposed to programs on a Housing First basis, which start with the housing and then offer treatment where uptake is much higher. Next slide. We have evidence from the HUD VASH program, a collaborative program between HUD and the VA, which has used only a Housing First model, where a housing voucher is paired with VA case management and appropriate supportive services. It has found that it has kept veterans housed. They have found that veterans, as opposed to those in standard care, had fewer days using alcohol and/or drugs, increased appropriate healthcare utilization. And we've seen overall that with appropriate investments, veteran homelessness has decreased dramatically over the past decade while they've adhered to these Housing First policies. Next slide. Housing First works for those with severe behavioral disabilities. It works through these programs like permanent supportive housing, which shows subsidized housing with linked supportive services that are voluntary using a Housing First model. Next slide. Permanent supportive housing has been shown to keep people housed. A meta-analysis found that permanent supportive housing offered on a Housing First basis increases long-term housing stability for those with moderate and high support needs. In an RCT that we did, targeting chronically homeless people who were the highest users of services, we found that PSH housed almost 90%, and by the time we finished the 7-year study, over 90% of those offered, versus 36.2% housed in usual care. And once housed, participants stayed housed for about 93% of the next 3-year follow-up. Next slide. Permanent supportive housing improves some health and healthcare access measures. While not consistent across all studies, permanent supportive housing has shown positive benefits for HIV outcomes, including decreased new diagnosis, decreases in viral load, decreases in mortality, medication management, preventive screenings, and non-acute healthcare utilization, such as mental health and physical healthcare offered in outpatient. I would also challenge you to think that if we could get the housing to people earlier, would these positive outcomes be even better? Next slide. There's some evidence to support that PSH improves mental health with possible improvements in depression, anxiety, and problematic substance use across studies. Next slide. Housing First is a philosophy. Not everybody needs permanent supportive housing. Some just need the housing without the services, but the principles of Housing First remain the same. We need to remember that it is housing in the end that ends homelessness. Next slide. Housing is foundational to good health. Housing First keeps people housed, but has limited, but sometimes it can be hard to prove all of the health benefits. That said, the health benefits are accumulating and impressive. Everyone needs housing that they can afford, and our solutions to homelessness have to start there. Next slide. As I like to say, as a physician who works in the homelessness space, there is no medicine as powerful as housing. Next slide, and thank you so much, and I'll turn my video off.
Thanks, Margot. That was great, and you laid a great foundation for how we then take what you've shared and begin to show how it can be implemented. I want to remind folks that, or let folks know that we're going to take questions after the panel is complete. You can use the Q&A box to send those questions. That's the best way. That way we can keep introducing each other in the chat, and I won't lose track of any of the questions. And with that, I'm going to pass it to Whitney Joy Howard. Whitney is a housing team unit manager with the state of Washington's Department of Social and Health Services. Whitney.
Thanks, Peggy. Hi, everyone. Whitney Joy Howard, she, her pronouns. As Peggy said, housing unit manager for Washington State's Aging and Long-Term Support Administration, or ALTSA. We're the long-term care system in Washington. Per AARP, we are one of the highest rated long-term care systems in the country. And I note that because we have built up a robust package of services to support people who wish to live independently, be able to age in place. And one of those is our Housing First or supportive housing benefit. Some quick background, try to be quick, on the why and how of growing Housing First in Washington through the state. A few things happened. Washington is a Medicaid expansion state, so we saw more younger single people with complex behavioral health challenges, mental illness, substance use disorders, people with physical disabilities being eligible for and coming onto our services. Specifically for the long-term care system, we took part in Centers for Medicare and Medicaid Services, CMS, Money Follows the Person demonstration, which provided us the opportunity to create more services to support people exiting institutional settings, namely skilled nursing facilities and longer-term acute hospital stays. With Money Follows the Person, we created a community choice guide service, which is essentially a housing specialist or housing navigator people with housing experience, helping clients search for and apply for housing, and then helping them move out of skilled nursing facilities into their own homes. We also created financial support for these transitions, funding to pay for background checks, application fees, move-in funds, furniture, essential household items. So we had these services, we had funds, financial assistance to aid the transition, but we soon found that we weren't transitioning people out of skilled nursing facilities through Money Follows the Person because they didn't have access to affordable independent housing. So we created a housing subsidy, a state-funded housing subsidy, and a statewide housing team to support the creation, development, and growth of affordable independent housing resources for ALTSA clients. The approach we took with our subsidy was it's temporary to bridge the time between needing to exit the institutional setting and the time it took to secure affordable permanent housing. Basically, we would cover the time a person was on a list for their name to come up at a tax credit property, senior housing voucher through a public housing authority. And our statewide team of housing program managers in the meantime, we're also working with our local public housing authorities in Washington, building relationships to pair our home and community-based services with vouchers and then be able to get direct access to those vouchers. That was in 2011, 2012. And as we moved along with the Money Follows the Person demonstration, we identified that support in navigating the system, securing housing worked well for many people, but there was a certain population of people who needed additional support once they were housed. The person leading the Money Follows the Person demonstration for ALTSA in Washington was my boss, Liz Prince, who was an executive director at a homeless shelter in Northern California prior to coming to Washington State. And she is a huge champion of Housing First and basically became the squeaky wheel to bring on Housing First or supportive housing services. A few years later, Washington's Healthcare Authority, Division of Behavioral Health and Recovery, so our behavioral health entity, and ALTSA came together to request an 1115 waiver through CMS to create a Medicaid benefit for supportive housing using Housing First principles. There were some key people like Liz from each of these state agencies that had background and experience in Housing First and recognized the need to bring more funding in to pay for this intervention. So these 3 state agencies each came up with target populations they saw as needing more support than they were currently able to receive, which created this pretty expansive eligibility criteria for the benefit. And it also created an opportunity to use Housing First as homelessness prevention. So basically we have criteria related to people meeting HUD's definition of chronic homelessness, but we also have eligibility criteria for the Housing First benefit, supportive housing benefit for people with lengthy institutional stays, in and out of residential facilities, people who are high utilizers of Medicaid, in and out of emergency service healthcare response systems, and also people who have frequent turnover of caregivers and have challenges stabilizing their housing as a result. At the same time that ALTSA was working on an 1115 waiver request back in 2016, our governor's office prioritized funding for transitions out of Washington State's 2 psychiatric hospitals. ALTSA was giving funds to support transitions, and we took this opportunity to bring on a Housing First program directly under ALTSA for us to administer. And given our experience with Money Follows the Person, we knew that we needed to fund both the intensive pre-tenancy and tenancy sustaining services, as well as a housing subsidy. So we actually created a state subsidy to support for the smaller kind of boutique Housing First program within our state. We created that state-funded subsidy to support the Housing First benefit as well. So quickly, just to sum up the why of bringing on Housing First in Washington, there's the need to bring on new services to meet the needs of a growing and expanding population of people. There were some key people who had personal experience working within the world of Housing First and were believers in the model and were able to advocate within their leadership structure to bring on the model and also take advantage of this larger push from some national entities to bring support bringing Housing First into the Medicaid benefit world. And then there is this reality that institutional settings, facilities, emergency service centers, these are all extremely expensive systems. And when you have people cycling through these extremely expensive systems, it's very costly and very traumatic, and nobody wins. It's just this awful, expensive cycle, and we need to do something differently to stop it. So Housing First, speaking from long-term care specifically, Housing First and that rent assistance is a much cheaper alternative. So that created a lot of buy-in within our state systems and within our legislature to bring on this benefit. Switching to provider support side, what ended up happening with our 1115 waiver, CMS did approve that, but the Healthcare Authority brought on a third-party administrator for that 1115 waiver supportive housing benefit. And that's a much more expansive pool of people who are eligible and enrolled in that benefit. That's that kind of broad criteria I went over a moment ago. Then we also have this smaller boutique Housing First program directly administered through ALTSA. Both aim to create a more collaborative, active working relationship between community partners, community providers, and our state funders. We do this through a lot of training. We provide a lot of free technical assistance and support. We have dedicated staff at the state level who are very accessible and in frequent communication with contracted providers. The majority of staff at the state level are people who worked in direct service within Housing First and/or have lived experience. We're believers in Housing First, and we want to create a permanent benefit in Washington. So we do a lot of work to support our providers in supporting our clients. We've also built some fantastic cross-agency working relationships to ensure we're not duplicating processes, but working to create equitable and broad coverage and eliminate service gaps through through federal and state dollars, which again helps us in getting our legislature to be supportive of us, because we're working to make sure that we're covering different kind of parts and not duplicating or asking for the same benefit or service across state agency. Focusing on ALTSA's Housing First program specifically, we call it the Governor's Opportunity for Supportive Housing, and it's for our clients who are exiting or diverting from our state psychiatric hospitals. This is an intensive tenancy support program with the rent assistance. Our supportive housing providers aren't behavioral health providers, they're not long-term care providers, but they work in partnership to facilitate this cross-sector team of care and pull in other staff with other areas of expertise as the needs arise. As the state, we're able to track a lot of information, listen to our providers, and we're able to bring all of that to our state legislature when we're looking to increase funding or expand our programs. And basically, as the state, we have the same goals as our providers. We want to support our more vulnerable residents stabilize in housing and receive the support they need. We want to work in partnership with our providers to meet these goals and to do our best to make sure that our providers get the resources and support they need. And with that, I'm out of time right now, but I'm happy during Q&A to speak more specifically to some of the ways that we, as the state, work in partnership with our providers and work together to create these collaborations and not kind of work to look to ding our providers, but work to support them.
Thank you, Whitney. Next, our next speaker is Christy Respres, who is President and CEO of Pathways to Housing DC. Hi, Christy.
Hi, Peggy. Thanks for having me. Excellent. And thank you, Whitney. So I am going to speak from the provider perspective here, a little bit about Pathways very quickly. So I'm the president and CEO of Pathways. I've been with the organization since we started in 2004, where we were the first replication of Pathways to Housing in New York City, who created the Housing First model. So if you can advance the slide for me, that'd be great. This is just our mission. Pathways, we are a housing first agency. That is our core, that is our mission. We're serving people experiencing long-term homelessness without using the Housing First model. So I'm going to talk some more about our programs for a few minutes and the diversity and how we've changed over the years and how our healthcare services have grown. So if you can go to the next one. So at Pathways, we have three primary services. We have our kind of front door services, which are homeless street outreach. We also provide case management in a downtown, like a drop-in center with like a one-stop shop for people experiencing homelessness. We also have 3 Housing First programs. I'm going to focus on that today. And we also have a behavioral health clinic where we provide services and urgent services in the DC Superior Court. So if we can go to the next slide, I'm really going to focus on this conversation again on our Housing First programs. We have people, which should not be probably surprising, the people in our Housing First program really mirror people experiencing long-term homelessness in our community. We are prioritizing people experiencing chronic homelessness. So you can see some of the statistics here. I won't read off of them, but not surprisingly in the district, you know, most of the people, at least over half of the people we're serving are over the age of 55 and aging. Since we have had a Housing First program since 2004, we have many original tenants. And so we are starting to skew as many, we talk a lot about this, people are starting to age in place, and we need to talk about what services are changing, how are we modifying our ACT teams, our Housing First programs. So I'll talk some more about that in a second. But if you can go to the next slide for me, this is where I want to talk specifically about our Housing First programs, the theme of today, right? So Pathways started in 2004. We brought the Housing First model to the district. We started out serving 55 people on one assertive community treatment team. We have grown to now have 813 and expanding daily people in our scattered site Housing First program throughout the district. It also a little bit in Maryland. We've expanded a few years ago. We started with the Pathways Housing First model of ACT, meaning if you're not familiar with ACT, assertive community treatment, which is the highest intensity behavioral health service you can receive in the community, partnered with a permanent housing, so that traditional Pathways Housing First model. And then we've grown and expanded. The district in DC, the district moved to a Housing First model continuum-wide in 2008 using an intensive case management model. So it's a 1:18 as the staff to client ratio. So we have, again, the assertive community treatment Housing First, our case management Housing First, and also a veterans Housing First program serving 100 veterans, which is a modified ACT team because not everybody served by that program has serious mental illness. So it's staffed by nurse, peer specialist, substance use specialist, not a psychiatrist. We're really trying to connect people to the VA. Why I share all this is that we have seen over the years that, you know, we know, and I see some of the chat in here around the different services that people need. And what we know at Pathways, and I think this community knows, is that Housing First is not housing only. That word first is really important. And actually, if it was more accurate, it'd be housing parallel. So at Pathways, we know that we are targeting people who are needing the supportive services to be successful. As Margot shared earlier, that's not everyone, but the people we're working with are really need some supportive services. It changes over the time, the level of the services they might need. We know that people recover from serious mental illness and addiction much faster than they recover from poverty, which is why that permanent housing subsidy is really important. But we know that we have to customize the services based on what people need and what they are asking for. So, you know, if you're not familiar with the ACT model, it includes a nurse, substance use specialist, peer specialist. In the District of Columbia and in Maryland, where we work, those services are paid for by Medicaid. And it's really, really important that we're matching people with the right level of care. And I hear this around the country, some of the frustration and challenges where people are trying to put forth a really strong Housing First program, but they don't have the intensity of services. I saw that in a Q&A a second ago where the services aren't matched. So at Pathways, while we're giving people choice, of course, and how often they see us or do they see us, we are very assertive, not aggressive, but very assertive in our offerings of services and very creative. That means if we need to see someone every day because their mental health needs are so high, then we need to do that. It doesn't average that high typically, but if we need to see people that frequently, we are. Another thing that we know though, and I've seen this in working in Housing First for over about 23 years now, is that housing is, we say, right, healthcare, and that's like a first step, but people need literal healthcare as well. And that's where the physical primary care health and behavioral health services are so critical. Not everybody has all those services baked in. We have expanded our programs throughout the years and layered on services. So I want to talk a little bit about the literal health services that we've layered into our programs and that we partner with in the community. So I would say our first ACT team, the very first thing we learned is you get what you pay attention to, and it's a mental health program. What we found there, and that's perfect, in that mental health program is we weren't doing a very good job at first tracking people's connection to primary care, even though there was a nurse on the team. So making sure we track the data on connection to primary care seems so basic, but it was a really important and critical thing that we continue to do. What we learned early on is that not everybody was accessing primary care in the community. So we had to get creative and think about how do we layer that onto our services. So we worked with Unity Healthcare's on this slide in the District of Columbia. They are the healthcare for the homeless grantees. So we worked with them and they were really creative with us in setting aside some appointments in their clinic so that we could bring anybody that day to just come and use that appointment. That was great for a group of people. But there were still people who were not getting connected to care. There's a lot of mistrust in the medical community. People have not always received the best care. And so I will say the next thing that we did is we received a SAMHSA grant and integrated the primary health care onto a clinic on site at Pathways, which really helped us in that care coordination, having our case management team, our ACT teams being able to directly communicate with the provider, with the healthcare provider, and coordinate that care in very creative ways, really critical. Most recently, and you see that Elevance Health logo there, most recently, we were really excited to receive a very generous grant from Elevance Health, where we are now providing that next level of care. We're finding that over the years, we know that while we are successful in connecting a lot of people to primary care and behavioral health in the community, there are still a group of people who need visiting home care. So we have a nurse practitioner who's working with us from Healthcare for the Homeless, Unity Healthcare, doing very strategic and focused home visits that are triaged to people who are at the highest level of acuity. They have the most complicated health challenges, and they're not trusting of the medical community yet. So that home visit, a case manager is going with the nurse practitioner where they are creating and establishing that rapport and that trust with the ultimate goal of connecting people to healthcare in the community. I'm sharing a couple of these examples to say we didn't have all this day one. We've really evolved over the years to see and continue to ask the people that we serve, what do you need? How can we help? And trying to layer on and connect with the other resources in our community. Another example, and then I know I'm coming up to time, is, even with our veterans team or our case management team, sometimes people need an assertive community treatment team or more intensive behavioral health services. We don't always have capacity, but that doesn't mean that, of course, we're waiting. We're connecting people with those services in the community. So I'll pause there because I think I am at time, Peggy. It goes quickly, 10 minutes, but the key to this is that I cannot emphasize enough that housing first without services is not housing first. There's, again, that philosophy versus the practice. And so making sure we have the right services matched to a person's level of care and what they need is absolutely critical, whether you do it in-house or whether you sub it out and connect with others. So thank you. And I look forward to some of the questions being answered. Oh, I will just say, thank you for the earlier research. We also, tracking over 18 years, have a 90% success rate. Not us, but our housing. People are staying in housing about 90% of the time.
Great, thanks, Christy. And during the Q&A, we can dive into that deeper. So I invite all the panelists to turn on your camera as we enter into the Q&A portion. I want to let folks know, you may have seen that Eleanor Bradford was on the agenda. Eleanor is the Senior Program Director at Turning Point in Macomb County in Michigan, but was unable to join us today. So we'll make sure that if possible, when you get the recording of this, we also include some links to any information that she had planned to share, if that's available. And so we have a good bit of time for Q&A, and I Just want to start back, Margot, with you. And, given what you heard from Whitney and Christy in particular, is there what from a research perspective and what we know about Housing First, are there things that you want to point to pull out from their presentations?
Yeah, I think the presentations were fantastic and get at, first of all, what I would call the difference between sort of big P policy, like that it is very clear that housing first is the way to go. And this small P policy, we can't lose sight of the implementation on the ground. And I think something that I think Christy just said near the end and repeated, I want to lift up, which is that, we said housing first isn't housing only. That's absolutely true. And Christy really emphasized and re-emphasized the need to match the services to the individual. We need to realize, first of all, that individuals vary widely. Some are going to need a very intensive service model, some might need a moderate service model, and some really might need very light touch services if they are already, places that have abundant housing or things like the VA, which is getting to people early in their course, find that some people really need that permanent voucher, need housing navigation services, need some light touch, and then they're good to go. And also to acknowledge that people's needs change over the course of their life. Permanent housing is permanent. They may need that rental voucher forever, but their needs may go up and down. And really the best evidence-based programs are one that can match their needs. I'm seeing in the questions some very real questions about, well, how does this look on the ground? And, we're hearing that, there can be difficult situations or chaotic environments or whatever that really may be more of an implementation practice. That doesn't mean that we need to do the opposite and go to treatment first. We know treatment first doesn't work. You wind up without either the treatment or the housing, because as a clinician, I can tell you it's very hard to engage people in the work of treatment when they're trying to figure out where they're going to sleep, how they're not going to freeze to death, are they going to get sexually assaulted out, in an encampment. It's so much easier to do that engagement once they have the stability of home. But it is also true that we need to match the services to the needs and not, for instance, have very high needs people without the services that they need to thrive. In medicine, we do this, we try to do this naturally, right? We try to do like you match the services. We don't all succeed, match the services, what people need. Housing first works, and we need to have flexibility, and we need to have the services that people need.
Thanks, Margot. And along those lines, Whitney, there was a question in the chat. And if you have questions that you put in the chat, if you could make sure to put them in the Q&A box, it'll be easier for me to find them. But one that flagged for me because I know a little bit about the work that y'all have done in Washington State, and it was around rural and doing this in a more rural setting than an urban setting. And I know that some of the early success as Washington State was launching this was actually on the eastern side of the state. I want to get right, the eastern side of the state. And so could you talk a little bit about what you've seen and the partnerships in smaller communities and how that's worked?
Yeah, so thanks, Peggy. So I came to the state. I had worked for Pathways to Housing DC, actually, and then Pathways to Housing National. And I think I had an expectation of service provision coming to the state. And then when you go into the world of having to contract with providers, and especially as the long-term care system trying to break into more of the homeless service and housing world, it was an experience. So basically what we ended up doing was any entity that has the will, heart set, mindset is there. We're going to contract with you, and we're going to work with you and bring you up to a quality of service to support you getting to where you need to be and to pay you to get there as well. So when we looked to contract with our providers, we did end up having a lot of providers on the eastern part of Washington State. Seattle is in the west. That's where I am, in the western part of Washington State. Long been a proponent of Housing First. permanent supportive housing. There's a lot of housing and services kind of built up and established in Seattle, in a specific model. And so, you know, statewide, though, there were a number of, I think, providers who saw the need in their community, and there wasn't an established service or network working to support a population of people. Or we had, going back to our work with Money Follows the Person, we had community choice guides that we already had contracted and established doing that housing search part of the work, who expanded into, you know, they saw the need to support their clients once housed, so they jumped on the opportunity to then expand into the world of supportive housing services to provide that continued support once somebody was housed, and to work in partnership with the other systems that exist within our behavioral health system, within medical services, and then within our long-term care world to help people age in place through personal care services or other, you know, durable medical equipment, skilled nursing, adult day health, things like that, the other services that we've created. And so we had providers who saw this need and kind of stepped up to work to support that need. And we had to work with them to find, especially in the more rural areas, to find the right mix of this is the quality we're looking for, and this is the reality that you're facing. Our two state hospitals, one is in Spokane, which is all the way on the east, and one is in basically outside Tacoma on the west. So providers in the middle of the state, we were requiring that within 10 days of receiving a referral from the state hospital, you had to go in person to meet with a client to start that relationship building process, to create rapport. So when they discharged, that was already established and there was more opportunity to be engaged with that individual. For those in the middle of our state, which is pretty rural, to get over to Spokane, you know, we heard of providers having to go and spend the night in a hotel to be able to meet with the client. So that obviously was not going to work, but we wanted to make sure that there were opportunities for rapport building. So we worked with that provider to use virtual visits, essentially, to be able to have some time to engage with the individual, but also one that wasn't gonna make the program not workable from a financial end for that provider. So we have to kind of adjust as we go based off the needs that we were seeing. We also, just speaking to what Margot was sharing before, that we originally set out as pre-tenancy one rate. Once somebody was housed, this flat rate, and we found out that there were some individuals who, as time went on, to tailor that support, and as there were crises that occurred or this ebb and flow of service need, the flat rate was not workable for providers to actually step up and to provide the level of support somebody may be needed. So we were able to adjust our rates in our contract to be able to quickly kind of switch between rates dependent on what that person needs, so that they had the ability to really tailor the support and be there for that person to help them stabilize in their housing.
Great, thanks, Whitney. Christy, so you have now been at Pathways. You've seen it at Pathways DC from its inception. And so I want to pose this question to you. A few folks have asked, you know, what are the key and it's not as if it's a one-time activity to get political support and to inform policymakers. And you've helped national groups at the federal level and at the state level kind of engage policymakers. So can you talk a little bit about, you know, your experience from when Pathways to Housing started in DC, what it took to get people on board with the idea of housing first in the work that Pathways does, and then what has been working ongoing to continue that support and to also be a great collaborator with us at the national level as we educate policymakers in Congress and the administration.
Okay, I could talk about this stuff for hours, but I won't. So I'll try to be succinct. Yeah, it's been an incredible journey. And I will tell you, when we first came to Washington, D.C. in 2004, there was a lot of skepticism. Because we were focusing on working with people who met the ACT level of criteria, I'm speaking mostly about mental health providers in the district. We actually had a very hard time getting anybody to refer to us because people didn't think it would work. They thought mental health agencies who were serving people who were living on the street for many years thought we would be setting people up to fail if we moved them into housing, because they didn't understand that it was not housing only, that was housing plus services, right? What then happened is we did our own street outreach, and we got referrals from places like Healthcare for the Homeless or local drop-in centers who were just jumping at the chance to refer people who didn't have those preconceived notions about who would be successful and who wouldn't. You know, fast forward a few years, what started to happen and how the hearts and minds changed, and we see this around the country, is they saw that it worked. People in the community, mental health providers started to say like, oh my gosh, I was working with Mr. Jones for 15 years and he was never successful in our housing where we required psychiatric treatment compliance, and he's doing well in housing now with the Housing First model. And I think so that was an evolution where people needed to see, and we have that now after, you know, several decades of now of Housing First. We've seen that all over the country, that and out of the world, it works. The scale piece was really important in the district, the political will, right? Back in 2008, the district government said, you know, there was challenges to end homelessness by the National Alliance and the others at the federal level to say, let's not just maintain homelessness, but end it. Well, you have to have a plan and a model if you're going to end homelessness. So the district itself decided to, I think kind of like Whitney was sharing, like to invest and said, if we're going to move the needle and end chronic homelessness, we have to do the one evidence-based thing that works, which is Housing First. They used a case management model. And the interesting thing was that it brought along people who were not doing this work before, which was really important. So mental health providers who might have been doing housing like group homes and things started to do this different model because they saw that the success in Housing First was actually higher than the success rates in their, you know, traditional group homes. It also brought along other providers into the space who before were doing things like doing drop-in center services or meal programs. And I think that's really important because it wasn't just, again, big mental health agencies, but it was people starting up who had the right, as Whitney was saying, the right philosophy, the mindset, the belief that recovery is the expectation for people, right? So that's been a really powerful evolution that I've seen around the country in DC and elsewhere. I think, of course, the cost-effective piece is a really important argument. That's helped with our managed care partners. Like we're really now kind of what's happening today is we're seeing things like managed care organizations speak to us about how can we partner with Pathways around helping their constituents who are on their healthcare plans, who are really high utilizers of healthcare. The other side of that, and this is I feel like I have to say this in every conversation, is we are not just focused on high utilizers, but also we're deeply concerned with people who are not utilizing healthcare, because those are the people who are literally quietly dying on the street without calling the ambulance. And so it works for all of that, Housing First. And so I've seen this evolution now in terms of the continued advocacy around how do we leverage different payment vehicles, right? And DC, I put it in the chat, we have been contract funded with the district for years, since 2008. We just as a city moved to Medicaid funding for tenancy support services a few months ago, which allows us then to leverage the savings that the city was, 100% covering this program, thousands of people. Shifting that expense to Medicaid has really now allows us to reinvest those dollars in more housing, in training, or whatever the things that we need as a community. So I think, I would just say it's been so powerful to see the evolution. And I know that there are many people who are trying to equate Housing First with increases in homelessness around the country. The math just doesn't work. We have increases of homelessness because of all these other issues. So those are symptoms we're seeing, right? Of continued lack of affordable housing, continued lack of livable wages. So what we do see is it works and it continues to work. And that conversation, I have to say, Peggy, hasn't changed. It continues to be the same. So yeah.
Yeah. Margot or Whitney, are there things you want to add around things that have worked message-wise?
I was just smiling when Christy mentioned the cost effectiveness, because in thinking about this presentation, I was like, do not say cost effectiveness right out the gate. It's true, but like, not like where my heart is. But I did respond to a message in the chat. It does help you kind of move things, especially in Washington when we're looking to get funding from our state legislature, when you have these very costly settings where we know people are kind of cycling through, and then you have the cost of services and housing to compare. So for instance, in our state hospitals, it's like $30,000 a month a person versus $5,000-6,000 for rent subsidy, for supportive housing services, and for home and community-based in-home services. So it's, that definitely helps the conversation. We've also, in terms of buy-in around, people within our systems, within the behavioral health system, within our state hospitals, to help refer clients and support us in building up our programs, being able to bring in individual voice of their experience, to be able to directly speak to the impact it's had on them, and being aware of our audience. When we have people who are discharge planners and work in treatment teams, from a behavioral health standpoint, if they're seeing someone cycle back, they're not seeing all the other people who have not cycled back through the system. So to kind of help with that conversation of, yes, some people, will be in and out, and it's going to take longer to stabilize them, but this is what they want. And we need to continue to figure out what is the right match of services when we have them, during these discharge planning sessions, to get them back out in the community. And just because it didn't work the first time doesn't mean that they don't have the right to live independently again, or that they have to go to a treatment facility, or they have to go to some very expensive kind of behavioral health facility to live, because that's not what they want. And those settings are not actually going to support their needs, and they will be here again regardless. So let's figure out what other services, what array of services we can provide that person. And also for our standpoint, to make sure we're also highlighting the stories of all the people you're not seeing come back through and who are out there and are stabilizing in their housing.
Yeah, that's a great point. Margot?
I was going to say, I live in a state, California, whereas a National Low Income Housing Coalition reminds us all the time, we have 22, maybe 23 this year units of housing, ELI housing for every 100 ELI, extremely low income household in our state. We're 1 million units shy, and that has left this sort of wide opening for some people to claim that Housing First doesn't work. And just to remind people, like when we're talking about Housing First, we're talking about a comparison to Treatment First or high threshold housing. And in fact, what Treatment First or high threshold housing does is leave those precious units empty, right? Because people are getting kicked out or they're not coming in. You've got that, expenditure we just saw on BART, where it's really hard to engage people in treatment when they're not housed, and therefore you waste the units that you have. I think we need to do a better job narratively of sort of separating these problems, right? We desperately need to close the affordability gap. We need to increase our supply of ELI housing. But our failure to do that should not somehow confuse people to think that we should go back to old models of using the housing that we have, to models that serve nobody's needs. It's not going to make the public happier. What it does is it takes people and really leaves them without, unfortunately, both treatment and services, and frankly, leaves those precious units empty. Where what Housing First does is it says, what is the best way to use the units that we have while we fight like heck to increase the availability of those units, to decrease the insidious effects of racism, to decrease the income inequality and just the lack of planning and building of affordable housing. Like, we need to somehow say, like, why would we go to something that we know doesn't work? Frankly, it doesn't treat or house people. Let's use what we have the best we can while we expand it. But certainly on the West Coast, we're seeing pushback against Housing First because people are conflating those problems. And I think we need to really be really clear about the choices that we're talking about. And then I think, as I think both Christy and Whitney spoke about so beautifully, like we need to do it right? Being able to staff things appropriately, like in healthcare, we don't treat leukemia with a Band-Aid. Like, yes, people bleed because of leukemia, but like we need to treat it with what people need to get well. And so we just need to be sure that we're matching those services to the needs. And then I think the rest will hopefully follow.
Great, Margot. So along those lines, Christy, I'm going to start with you again around, there have been a few questions about engaging landlords and how to find housing in tight housing markets. So I wanted to push it to, send it to you to talk a little bit about your work in that space.
Sure. And we have a huge audience here because I will tell you, probably of these 1,400 people I'm seeing on here, we probably have 1,400 great ideas on this. It is really key. First of all, you just have to, the basics are still true as they were, 15, 20 years ago, is really understanding what do we have to offer landlords. One is it is a service-rich program, and that is not anything that they get from the general public that they're renting to, right? So knowing that they can call on us if they're concerned about someone and that really are the partners, the landlords, that is a big selling point, right? People have rights and responsibilities, of course, in housing. They're holding leases, and landlords, to be able to have someone to call to say, hey, we're concerned about a tenant. Can you help make sure they're understanding how to take out their trash, right? Because we see it in the hallway. That's a big selling point. Sounds basic, but it's a big one. Also, the guaranteed rental streams is a big, big selling point. So again, knowing these basic selling points to them is a big, helpful kind of, I would say, helpful thing. And the tight market, we have nothing that's more unique than anybody else, but things like DC has done some things like, and I see some of the chat here, especially it was interesting a few years ago around rapid rehousing. There was a lot of landlords who were very concerned and hesitant. So they there was a creation of a landlord fund worried about people who were damaging an apartment or so, but it was for new landlords coming into the system. We need that for existing landlords. But that was a great way to try to get new landlords. I will say this, DC has some of the highest tenant protection laws in the country. And for me, that's what really works, is that there should be no community in this country where vouchers are not an acceptable form of rent payment. So, part of that advocacy is on us. I just want to say that out loud to keep pushing for those laws to be changed so we don't have to do as much convincing for the landlords as we do upholding the law. But those kind of incentives are helpful. Also, word of mouth. I mean, the best connection is another landlord saying, we love working with Pathways because they follow up, they answer the phone, et cetera. And even when someone has a challenge, they respond. So that landlord connection of other landlords that build success, a couple of creative things. I'm sure, again, lots of ideas that people would put in the chat for each other, I think will be really helpful too.
Margot, I want to pass to you. There have been some questions about housing models and whether one shows better health outcomes than others. Can you talk a little bit about that?
I think it's a really important question, the question of like scattered site versus project-based. And I think I would say that evidence-based is nascent. I've started to read some small studies about it. I think the way I think the answer is it depends, right? And that what you want is flexibility. The advantage of the project-based is sometimes you can really put services sometimes right in the building. People can share services as the population ages. I think we're going to see more and more need for and response for things like personal assistance that, like, we're seeing some really innovative models in San Francisco where they have Medicaid funded home and community-based services, personal assistants who are shared throughout multiple clients in a building, and they can use them for 15 minutes and then use them for 15 minutes again. So there's some innovation there that's really important. I think we're also seeing places like, let's say, San Francisco, which has relied almost exclusively, not only on project-based, but a project-based in a really small, concentrated area, that you have extreme concentrated poverty, extreme concentrated sort of quote unquote street behaviors and things that are probably not optimal for everybody's healing. And so I think the answer, like everything else, is it depends. It depends partly on community context and what's available, but I think it also depends on the individual, that there are some people who, being more in the perhaps in a community with less services, but also perhaps less concentrated poverty, may be able to thrive better, and others who really could benefit from the buildings. I would say that The research is nascent, and for those researchers out there, I think this is a really, really important area of research to better define what works best for whom and how you make it happen. I can tell you, like in the 7-year study that we just completed in November in Santa Clara, I presented data on the 3 years outcomes. I can tell you the 7-year outcomes were as good. You know, people, once they were not over 90% of the highest needs people got housed, and once housed, they stayed housed for 7 years for over 90% of the time. And you saw all the good things, you know, all the good things happen. They actually used a variety of models. It was really interesting. They had both project-based and scattered site in the same model, and tried to match people to what would meet their needs best.
Thanks, Margot. So Whitney, one of the interesting pieces about what you've shared today is that true collaboration on the housing in some places, right, housing and homelessness are not the same, right? So the housing world, the homelessness systems world, and the healthcare world. Can you dive into that a little bit more about, especially at the beginning of setting up that collaboration between those systems? And really in the healthcare, I grouped healthcare together, but there's also in Washington State, it's very primary care and behavioral healthcare are very different systems as well. So could you dive a little bit into like how you've coordinated those systems?
Sure. So I work for our long-term care system as well. And what I realized upon coming to the state was the homeless service world was more familiar with the behavioral health system and with the medical kind of partnering with clinics and hospitals, and not as familiar with long-term care. And I also had that problem when I worked, within homeless service world in Washington State. You think of long-term care, you think of residential settings, you think of skilled nursing facilities, somebody needs a higher level of care. And so they're moving from independent permanent supportive housing to long-term care. And that's not the case, especially in Washington. We have some really great services to support someone living independently. So one of the things we had to do was just get out there. We had a lot of people who came to work for my team who came from the world of homeless services, behavioral health system. And we just got out there and did a lot of trainings and educated people on our services and work. We had natural partnerships with the behavioral health system because we're focused on a population of people exiting our state hospitals. So we went and met with community providers. Our program in Washington State, we call ACT-PACT, Program for Assertive Community Treatment, outpatient providers, and just did a lot of relationship building and education around our services and working to making sure that our supportive housing providers were being responsive to the other kind of systems and providers. So when there was a need for them to support, they were there, and they knew who to call in from those other systems to pull people in for support. We created these monthly community meetings where we had people from, long-term care world, our caregivers, our long-term care case managers, behavioral health providers, providers from our homeless service system, medical system. We had all of these people coming together every month, getting to know each other, building relationships, and basically just kind of figuring it out and doing a lot of case staffing and figuring out how to work together and who does what. A lot of resource sharing. There's need for more resources across the board, but I think when we work more intentionally together, braid our services or consciously couple, like I like to say, of these resources, right there, you're going to stretch it. You're going to be able to better support people. And it's so much of it comes down with every single level to relationship building and spending that time creating those relationships, getting to know the different languages we speak and helping to kind of translate when you have somebody who comes from both worlds, being at that table as well to kind of get aligned in our language. But I mean, just honestly, a lot of conversations and a lot of time together, working through it and figuring it out. And in some areas, we have some really great cross-sector partnerships going. Other areas, there's high turnover, especially with impact teams. And it's just this constant training and coming together and trying to talk and trying to get together. Yeah.
Great, thank you. So we have a question in the chat about faith-based organizations engaged in Housing First. And I'll open that up to the panel if you want to talk about faith-based partnerships that you have in your community.
Let me say this, I am deeply grateful for our faith-based partners. We really couldn't do this work without them. And I think, and again, in the chat, I'm sure around the country, there are different people doing this in very creative ways. So where we get a lot of support is some of it's the basics sometimes, like people have relationships with people in the community. Many of our faith-based communities have supplemental ministries where they're working with people who are literally experiencing homelessness and connecting us on the front door, building those relationships of trust, like some of those things, everything from there to ideas around helping just support people once they move into housing as well, in addition to the Medicaid support services. We've got, I know we've got lots of churches in the city here, like in, I think, a lot of urban areas around the country, talking about and doing work around how do we convert land that we have declining, declining number of people coming to the church. How do we use some of our land and redevelop it for housing? And so there's a lot of that conversation and some of that action happening, I think, around the country for churches getting into the actual work and partnering with other organizations and nonprofits or people who are doing the work to convert their stock. So yes, and yes, there was some other stuff in the chat around, again, extra support services, everything, even like the practical stuff, like furnishing apartments for us. So, the resource things are there as well. And I will say, church should be a welcoming place for everybody. And I say church loosely, like whatever that way, shape, or form is. And it's not always the most welcoming place for people with serious mental illness or people with substance use or people experiencing homelessness. But when it is, it's phenomenal. People need the community connection. People deserve more than a paid friend, right? Part of the Housing First model is getting people connected in the community. And for many people, that means a reconnection to a faith community. So I cannot speak enough about how important that is. It's about listening to the person. And if that's important to them, that's another very real way that people are supportive in faith communities.
Great. One theme that's come up in the chat that I want to see if the panel can answer, but I can add some things if not, has been around, we've talked a lot about Medicaid indirectly and the role that Medicaid plays in helping pay for the services. And so there have been a couple questions in the chat about what happens in non-expansion states that haven't expanded Medicaid to folks based on income level. And that means that people are still only eligible categorically, either because they're a pregnant mom or because they have a disability, and so I wanted to first open up, because all of you have probably been on panels at the least, or worked or done work in other states that haven't expanded Medicaid, to go ahead and ask that question. But I can also add to that question as well. Does anybody want to take that? Margot, did you? Oh.
I was actually interested in hearing your answer. I mean, in California, we've had a series of different, before Medicaid was expanded, there were a series of different revenue streams that drew on both local dollars, our Mental Health Services Act dollars, and things, but Medicaid, we hope, will be a real game changer. But I was actually partially nodding because I'm really interested, Peggy, from the national perspective, because, well, before we had expanded Medicaid, California has, a more service-rich environment than many other states.
Yeah, so I really wanted to bring up this question because I don't want it to be lost that there, in the in the compromises that were made that allowed states to be able to choose to expand Medicaid, there are obviously a lot of gaps in that. And so one of the things to look at is, while Whitney and I and others have talked about the limitations of cost effectiveness. Just because Medicaid hasn't been expanded doesn't mean that parts of the population that you want to serve aren't covered by Medicaid. So starting first there, people with serious mental illness that rise to the level of disability, the folks that Whitney have talked about, people in institutional care that that could live in the community but are unnecessarily institutionalized, starting there to make the case of how the things that Medicaid can pay for them when it comes to home and community-based services could be used to address, to either help people experiencing homelessness or help prevent homelessness in general, and then use that as a starting point. What some states have done, I know North Carolina has done this, is looked at like what are the services and supports that are needed in housing and match that to their Medicaid plan to see what services are actually reimbursable. And it just may be that the housing world calls it something different, or the providers in the housing world aren't Medicaid billers. And so first seeing what's built, what it could possibly be billed for Medicaid for, and then figuring out why it's not. Is the payment rate too low? Is, like I said before, do the providers not match and aren't Medicaid billable? And start from there, because it is really, especially it is, like Whitney said, making that first into how can we deliver comprehensive services to a population who's unstably housed or institutionalized, and starting there. And so that's what I would suggest is starting a conversation there with the state, which I know is going on. North Carolina in particular has really made some strides in being able to do as much as they can through Medicaid and has some great partners at the state level. So engaging with them, engaging in that effort, and then how to take it to scale, it might be seeing how the state can invest the state's resources at the beginning, as maybe this work could be another piece of the puzzle of making the case to why Medicaid expansion should happen.
Peggy, you just reminded me of something which was sort of early on when we built out a lot of our PSH before Medicaid expansion. One of the things that we found was actually there were a lot of people in PSH who were not on Medicaid when it was still categorical, were not on Medicaid. When they came into the stability of housing, the full assessment could be done, and they easily met the criteria for seniors and people with disabilities, but they had not been eligibilized before because of the chaos of their life. So and then partnerships with FQHCs, because I think whether it's a Medicaid expansion or not, I think you bring up a really important point is, do the people providing the housing know how to bill Medicaid? And so certainly partners with something like a federally qualified health center to provide some of the services. But I just wanted to lift that up, that a lot of people weren't on Medicaid, but after they came in and were stabilized and assessed, they met criteria for categorical Medicaid.
Yeah. Yeah. And, a point that Christy kind of touched on is sometimes the behavioral health system thinks that they're serving our folks, and they're not. And that's a key piece of the puzzle. I've seen communities where they've done a cross data match between the continuum of care and people who have identified with say mental health needs and the mental health system or the main mental health provider in the community, and there's like zero match. And so being able to point out, no, look, it's not that these people, you blame folks for refusing care. It isn't that they're refusing care. It's that you're not doing what it takes to actually reach people. And that's another piece of the puzzle to raise up as to what how to make the case for directing services to the folks that we're trying to serve.
Yeah, and I want to, Peggy, thank you for saying that. It's really important. And I think depending in some communities how certain things are paid for, people aren't always incentivized to work with people with the most challenges. In a world of Medicaid where people are paid, like you have to bill by the unit of service, you're not actually incentivized in a mental health program unless there's a lot of accountability in your state or your city or your county to see people who might be saying, go away, I don't want to see you right now. Right. So there have to be a lot of checks and balances built in to make sure people are actually providing the service that people are entitled to the way that it was intended. And that is really important in terms of a quality of care. Yeah.
So Margot, we've gotten, in addition, similar to the question about housing model that works, we've also gotten some questions about populations that Housing First works for from a health perspective, veterans, families with kids. Can you talk a little bit about what we know in that space?
Yeah, I mean, the beautiful thing is it actually works across wide ranges of populations. I've yet to see it tested in any population where it didn't work. Although with the caveat is, I think Christina Whitney put it so beautifully, of like matching the services to the needs, right? If you put folks with very, very significant behavioral health challenges and you don't provide them adequate services and support, it doesn't actually work. It doesn't mean that they're required to take it. Like it turns out if you offer them in a low barrier way, people do take them. So I've seen it work for young adults, for families. I mean, I'm just thinking in my head of the evidence for elders, for people with severe mental illness, for people with severe substance use problems or co-occurring problems. We've seen it work for people exiting jails and prisons. People, I really like it. It's hard to find a population. I don't think we can find a population that it doesn't work for. The VA is an interesting model because they have more resources, because of the, we have buy-in that no veteran should be homeless in a way that we unfortunately don't have it for all communities. And I want to say full-throated, no veteran should be homeless, nor should anybody else. But because of that, they are able to offer services to a broader range of folks. You see in a lot of communities where only the most severely impacted sort of meet the threshold to get services. And what they have found is by varying the intervention, but doing it all on a Housing First basis, they've been able to serve, people with very severe needs and people with really very mild needs. But what they need to know is that they start with the housing and everything else follows, and that they match the services. So I think the answer to that, Peggy, is there's an evidence base for every population that Housing First, as opposed to any other model, is the preferred outcome whenever it's tested.
Thank you. And Whitney, we got a question about, so we talked about partners from the faith community. Can you talk about the partners you have among the nonprofit healthcare sector, and how they've been providing their, and whether they've been engaged through the community health needs assessment that they have to perform regularly?
So I guess, this kind of relates to my response before. I think we've seen a shift away. We've been trying to actively create a shift away from this kind of siloed service delivery perspective to better incorporate understanding people don't exist within one box of like behavioral health or healthcare or long-term care or homeless service sector or living in poverty, right? Like people exist across all of these. And we have systems in place that kind of are focused on one thing, and that is not the best user-friendly system. So what upstream is a better way to support people getting what they need that isn't burdensome or overly cumbersome, or having the same conversation with 12 different service providers and answering the same questions, or reliving trauma over and over and over again. So from the state's perspective, we hear a lot from our providers on how confusing things are, or how you have these different points that offer different services, and how can we better align across the different sectors and the different service entities to be able to create that wraparound service that is not overly cumbersome for the provider or for the user. So those are conversations and things we're looking at right now within our state, and ways to better work together and better partner with our healthcare system without creating permanent supportive housing facilities, I might add, because we do have concerns around basically creating residential single site settings by too much aligning with clinical medical services or long-term care, right? Like there is a need to be able to incorporate that community integration element and not just have everything within somebody's unit within a single site building. You know, you do need to be mindful and intentional about the ways that we're doing that. So we're not creating these little mini facilities, and we are actually having independent affordable housing. But ways to make sure that those services are there and for the individual through their medical services, behavioral health, and then long-term care. And one of the things I did want to call out for our long-term care system, especially with caregiver shortages that we were facing, we have, especially in our more urban areas, high concentrations of people on long-term care services within geographical areas, regions. So what we have started doing this thing that we call coordinated personal care, where essentially we have a caregiver assigned to a certain area, and they're able to work with the housing providers to provide the support people need to get their long-term care services. Even if they only qualify for a few hours, you have a caregiver there in that area, and they're able to more flexibly work with and meet someone and see them. If somebody needs like med management and they qualify for 2 hours a week or so, you know, they're not going to get daily service. But if you're able to have a caregiver assigned to a certain area, they could pop in for a few minutes a day to be able to provide that service. So that is, I wanted to call out coordinated personal care, because there is this concern around keeping people housed in permanent supportive housing and those kind of caregiving activity of daily living support needs. And that is a model that we're pursuing in Washington to better align with needs of our providers and needs of the clients.
That's great. I think what this webinar has shown too is that, you know, a deep, and from some of the questions, a deep dive into, you know, what does a team approach look like in Housing First, and who's part of that team, and how does it deliver care is another topic that that I think would get a lot of interest and is really needed from an implementation space. So before we get to some of the next steps that we want to talk about, I just want to give the panelists a second to be able to give any wrap-up thoughts, especially as it relates to, you know, the future. Like, what do you see as the next frontier for housing and helping people improve, for Housing First, as it relates to helping people improve their health? And I'll start with Margot.
I think we need to improve our messaging and make clear what the comparison here. It's Housing First versus Treatment First. One works, one doesn't. And then the second is we need to do a better job of implementation to make sure that we're leveraging all of our resources, Medicaid, you know, other sources of funding, to provide the services that meet the needs of the client. It needs to be personalized. And I think that's, you know, and then obviously we can't take our foot off the pedal of solving the EOI housing crisis. Those are the things that we need.
Whitney.
Yeah, I think we need to we need to work across our federal partners, our state, and our local funding resources to ensure that we have robust funding streams in place for the housing resources as well as the service resources. And part of that I just want to scream out is making sure that the people who are providing the services, the actual people who make Housing First a reality, are getting paid and supported by their supervisors and their agencies to be able to do the work and to be responsive to tailor those services to the individual. And then I'll also just say, if there are people in direct service with lived experience listening on this call and you're interested in expanding Housing First in your state, I say, please go work for your state government and help be able to build these programs and make sure they are adequately funded to support the needs of your state.
Thanks, Whitney. And Christy.
Yep, to all that. So I would have said all that, so I could say yes. I want to say, I know it's hard, and I'm seeing the chat in a lot of communities where some of these services aren't funded. And that doesn't mean don't do housing first. It means you do have to work harder and work more closely and creatively with your partners in every sector. And I think there are so many opportunities in forums like this to get in the weeds more and help elevate those kind of creative solutions. It is doable. And I think that the long term is, yes, you got to change the policy and make sure every community has these resources. And in the meantime, how are you leveraging every single resource we've got and get really creative? So thank you. We need all of it. And I do want to put a plug in for the prevention. We need to also be doing all the work on prevention so that by the time people are reaching us in homelessness, right, every single system has failed. So we need to keep elevating this and pushing up further stream as providers so that we're stopping that pipeline of folks coming into our system.
Great. Thank you, Christy, Margot, and Whitney. And I just want to leave you, next slide. I just want to leave you with some take action steps that the Low Income Housing Coalition, the National Alliance on Homelessness, and the Center on Budget and Policy Priorities want to make sure that you have access to, and this will be included when we send out the presentations. But first, there's this list of Housing First resources, letting you know, fact sheets on Housing First that we've all worked together on, and also helps give you some talking points when it comes to supporting Housing First in your communities. Next slide. And then, we really encourage you to take action in engaging the healthcare community. As you could hear from Christy and Whitney in particular, that outreach to the healthcare community, they get the Housing First very quickly and can be some of our strongest advocates in not just implementing Housing First, but also getting the resources that are needed to make it work. So coordinating with your federally qualified health centers, hospital systems, managed care in particular, because they can help with the payment piece, is really important. And then using the CSH map that's created to think about what I talked about before around what Medicaid can cover around housing support services is something to do locally if it hasn't been done already. And last slide. And one really specific ask that we have, what we're hearing more and more from policymakers, it is the need to raise up specific stories of how Housing First has worked for you or the people or the clients that you have. So we're starting this effort, and it's just getting off of the ground, but we don't want to waste any time of collecting stories. So if you are a case manager, service provider, a person who has benefited from Housing First, we encourage you to reach out to Elena at the National Low Income Housing Coalition. Share your story with her. We don't have funding right now to pay for storytelling at the moment, but we want to start to collect stories to start building the case for how we can build off of some of the great work that other organizations have done around sharing stories, because that makes it. That's what Christy and I know each other so deeply, because I can't count how many times we've taken members of Congress or their staffs to Pathways to Housing residents in DC, and it's made all the difference in the world. And I know other communities have done the same. So if you can help us by starting to collect those stories and send those to Elena, that would be fantastic. And with that, I want to again thank the panelists for a great conversation today. Thank all of you for taking the time to participate, and we'll see you on the next webinar, which is Monday, March 20th at the same time. Be sure to register in advance. Thanks, everybody.